Hi, everyone, and welcome to today's I3 Health interview. Today I'm joined by Dr. Aman Chauhan, who is an associate professor of clinical medicine at the University of California, San Francisco. Last year, he served as chair of I3 Health CME activity, optimizing neuroendocrine tumor outcomes, closing the gaps in diagnosis and care. And today he's here to share some additional updates that have occurred since recording the activity. Dr. Chauhan, thanks so much for joining today.
Thank you, Kiara. It's always a pleasure to work with I3 Health.
Absolutely, likewise. So to start off, would you like to introduce yourself and share what you do?
Yes, so I'm a medical oncologist and a clinical trialist. I specialize in management of neuroendocrine cancers, both well-differentiated and poorly differentiated carcinoma, and also do a little bit of theranostics with radiopharmaceuticals and phase one drug development.
Awesome. Looking forward to hearing some of these updates today. So since this webinar was recorded about 6 months ago in August, have there been any new updates in NETS treatment since then?
Yeah, it's very refreshing in neuroendocrine oncology, which used to see very limited progress. Now, every 6 months or so, we continue to see some advances, which is very refreshing to see. In last 6 months or so, I would highlight a couple of publications highlighting the growing incidence of burden of disease. One of the main publication came from MD Anderson, Dr. Arvind Dasari's group. They reviewed SEIR database and, maybe about a month or two later, our group followed through another SEER database review. So we can now say that the incidence of neuroendocrine cancer in the US have breached 8 per 100,000. And this is sometime considered as one of those barriers for rare disease. So maybe neuroendocrine tumors are not so rare anymore. So those were in epidemiology front. Now, we had cabinet study that we discussed in detail in our webinar, and that was the main uh, practice changing study in the recent past. In last few months, there have been occasions, that is ESMO meeting, where a subgroup analysis from lung nets has been presented. And I think that has been an important advance because, as we know, lung net is an important subgroup of neuroendocrine tumor. Unfortunately, not a lot of treatment options exist. The the or at least evidence based. There are very few clinical trials that have looked into drugs in lung net population. So it was very refreshing to see cabinet put a lot of weight in lung net. So they had a lot of patients. Almost quarter of their patients belong to thoracic neuroendocrine tumors. That means lung nets or thymic nets. So Dr. Jennifer Chan and colleagues, they presented some of the lung net subgroup analysis, and it looked very, very promising. Um, as we know, FDA has approved cabozantinib now for advanced progressive neuroendocrine tumor, regardless of the site. But it's good to see the data. In lung net population, what I remember, the median PFS was somewhere around 8 months as compared to around about 2.7 months in the control arm. So significant improvement in PFS, and vast majority of patients had stable disease on the treatment arm. So I think that has been a recent important recent update in neuroendocrine oncology world. Some of the other updates are happening in more high-grade neuroendocrine carcinoma side of things. Um, we didn't go into too much detail about poorly differentiated neuroendocrine cancers. Again, one of a rarer subtype of neuroendocrine cancers, very aggressive, very fast-paced disease, and a critical unmet need. So there has been clinical trials called Darion series of trials, which is testing a drug called obrextimig, which is a DLL3 T cell engager. And at recent NANETS and ESMO meetings, the updated data from these phase 2 and phase 1 trial, the Darien 5 and Darien 7, was presented. In fact, just last week, I presented Darien 7 further updated data set at AACR IO meeting. So it's very promising to see a great activity and safety of this DLL3 T cell engager in high-grade neuroendocrine carcinoma subset of patients. However, this is still drug in development, and we await for a registrational phase 3 study to enroll and read out and hopefully lead to newer treatment options for our high-grade patients as well.
Awesome. It's really exciting. There's been so much data just in the last, 6 months.
Absolutely, yes.
And you mentioned you presented the Darien 7 data recently. Any other research you're involved in that you'd like to highlight?
Yes, so one of our biggest and exciting meeting is about to happen next week in Poland. It's called ENETS, European Neuroendocrine Tumor Society annual meeting. And a lot of very exciting research will be presented from all over the world. I've personally involved in radiopharmaceutical related research, and I will be presenting data from a novel drug called peposertib. It's a DNA protein kinase inhibitor, and we have combined it to lutetium-177 dotatate, already FDA approved for management of neuroendocrine tumor in the US. And our hope is that with the combination of this very precise radiation sensitizer, we will be able to show safety and also some hints of efficacy in this multi-center phase 1 study. So I will be disclosing the results of that NCI-sponsored phase 1 study in about week and a half from now. And we are also working on another very interesting concept. It's in a phase 1 setting where we are using an oncolytic virus. These are the viruses that specifically destroy cancer cells and, in our opinion, neuroendocrine cancer cells. And we're combining this oncolytic virus with the conventional immunotherapy called ipilimumab and nivolumab. So this is a investigator-initiated phase 1 clinical trial that is currently enrolling patients, and we will be discussing or disclosing some of the interim analysis. So we are sort of halfway done with this phase 1 study. So I'll take this opportunity at ENETS to present the interim results from this first in human phase 1 study as well. Those are the important ones. Again, I look forward to also seeing updated results from Darien 5 as well as Darien 7 at upcoming ENETs and several other alpha PRRT studies. So a lot of very interesting drug developments happening in neuroendocrine oncology world, both for low grade as well as high grade neuroendocrine carcinomas. These are truly exciting times for our field, and I foresee a lot of very interesting data will be presented in 2 weeks.
Awesome. That's really exciting. Best of luck at the ENETS meeting and looking forward to seeing all the data to come out of it.
Thank you.
And in the activity, you spoke a little bit as well about the role of multidisciplinary care in NETS treatment. So what are some of the strategies that you utilize for team collaboration?
Yes, there are certain cancers where it is absolutely incumbent to have a multidisciplinary approach. Although it is ideal to have a multidisciplinary approach for most cancers, cancer management has become very nuanced, and there is involvement of all prongs or pillars of treatment, be it surgery, radiation, interventional treatments, chemotherapy, immunotherapy. But specifically for a disease like neuroendocrine cancer, where no two patients are alike, each patient has a very unique journey, a way of unique presentation, and varied management styles, right? So, and that may differ on institutional practices, expertise available, etc. So, it's highly important to engage in the multidisciplinary tumor board. So, at our center, we have a multidisciplinary neuroendocrine tumor board where we present cases, especially challenging cases, to our colleagues who comes from surgery, interventional radiology, nuclear medicine, pathology, just to name a few. I mean, uh, the difference in pathology from typical carcinoid to atypical carcinoid or grade 3 NET to NEC can change a lot of things in how we approach a case. Similarly, a nuclear medicine's input of is there enough somatostatin receptor uptake on dotatate PET can make all the difference between candidacy for PRRT or not. Similarly, a lot of our patients may be great candidate for liver-directed therapy, uh, and in today's day and age, we have a multitude of options when it comes to liver-directed therapies, different type of embolizations, ablation, and these days we even have non-invasive methods of ablation like histotripsy. So interventional radiologists are the best person to comment on feasibility of some of these techniques. So if we don't discuss these cases in a multidisciplinary setting, we would not get all those expert opinions and truly not do justice to patient in carving the treatment trajectory for them.
Absolutely. That's absolutely crucial. So thank you for sharing these strategies. Um, so with all the new treatment directions that you mentioned, as the treatment of NETs continues to evolve over the coming years, what are some of the directions and advances that you're most looking forward to seeing that go in?
That's a great question. And as a clinical trialist, I'm eternally optimistic about hopefully the next big breakthrough is around the corner. Both in well-differentiated NET world, we've made tremendous progress in last 7 years. But I think the next few years we'll continue to see that trajectory where we'll improve on the current treatment. So there will be these incremental improvements. I'm especially looking forward to see how some of these novel radiation sensitizer plus PRRT trials read out. I'm also very eager to know how some of the novel alpha PRRT trials would read out. And last but not the least, there are also some important trials that happened in somatostatin analog arena with subcutaneous injectables, and there is an ongoing study with oral somatostatin analog. Those are also very important studies, and I look forward to seeing them read out and hopefully change the way we practice neuroendocrine oncology. And on the other end of spectrum, the high-grade neuroendocrine carcinoma, that's an area where we have made very little progress in last 50 years. But finally, there might be some light at the end of tunnel. We have some very important clinical trials that are currently undergoing in the US and internationally. As I mentioned, Darien series of studies, one of them. There is also a cooperative group study that is evaluating role of conventional immunotherapy with chemotherapy in frontline setting. It's a SWOG study. So again, a lot of treatments or trials now finally investigating high-grade neuroendocrine carcinoma patient population. So this is certainly exciting times, and I look forward to see these trials read out in next 12 to 24 months.
Definitely. It sounds like the future is very bright for NETs treatment.
Absolutely.
An additional question, since we are getting ready to commemorate Rare Disease Day on February 28th, what is the importance of raising awareness of NETs, despite, how rare they are, and any message you'd like to share to, help raise that awareness?
Right. It's very important to continue to raise awareness about this disease. Um, because it was considered super rare, many patients or advocacy groups or physicians pay adequate attention towards this entity. But in last 10 years, we've realized this is actually a much bigger threat and a growing problem. As I mentioned earlier today, we have now a couple of publication showcasing the growing incidence of neuroendocrine tumor. That in turn means growing burden of this disease in the country. So that is causing us to change our thinking about this rare disease. We have to allocate resources towards studying this disease better, towards developing clinical trials focused on this disease. And I'm very happy to tell you that in last 7 to 10 years has been a seismic changes in terms of drug development. A lot of new drugs, trials, classes of drugs have been currently being investigated, and we have made a lot of progress. And that was possible because of continued advocacy. If we didn't really advocate for this relatively rare cancer, we would still be doing the same thing that we were doing 15 years back and had very limited treatment options. So continued advocacy is very important. Again, we are nowhere close to the cure, so we will stop when we find a cure. So we need continued support from all stakeholders, be it federal government, professional societies, organization, patients, patient support groups, sponsors, industry sponsors, and collaborators. So we all need to kind of chime in, work hard, and continue to do this incremental improvement.
Definitely. It's great to see how advocacy is really helping to propel progress for this disease. So
Absolutely.
awesome. So as we wrap up today, my last question for you is for those who are watching this interview, why should they check out the full activity on the website? What are some of the insights they can look forward to learning about?
Well, we try to make the full activity as comprehensive as possible, but at the same time, very uh, user friendly and easy to absorb and practical. It's not cut and dry data laid out. It's very, very easy to digest and understand such a nuanced disease with various treatment options. So I definitely would insist that give the activity a try, and I think you would be pleasantly surprised. The team from I3 Health have put in a lot of effort in fine tuning the graphics and the content around the educational material. Um, but I think there are a lot of nuances that you will catch on, and this is such a interesting disease that I think we have breaking it down systematically from definition to subtypes to how to manage it. So give it a shot and let us know how you feel.
Awesome. Well, thanks so much, Dr. Chauhan, for coming on today to share these insights with us. And to everybody listening, be sure to visit i3health.com to view this full activity and claim your free credit. So thanks again for coming on to talk today.
All right, my pleasure. Thank you. Thank you, Kiara.